Thank you, sir. Sir, you are there for the oncology part, sir. You're not there for surgical part, but thank you. And really, it's always an honor to come to any of Dr. Shyamagrawal's meeting from Gangaram. But it's very onerous to be with a very esteemed panel. Piyush is there. Bhuvan is almost there. Last to come in, Chandra Gowda is certainly there. And of course, Pankaj is there. So thank you very much. Uh, Bhuvan very nicely sat next to Dr. Harit to be on the oncology side. Uh, okay, so I think we'll go straight to a case. We've had some very good lectures about both the de-escalation of surgery and escalation of medical oncology. But basically, what happened was that uh, actually it's now time where the amalgamation of care is really helping for better outcomes. So this is a 58-year-old, and I do think, and these are disclaimers, these sites are actually not made by us, but I do think that Roche should be more particular about this. The definition of early breast cancer is actually different than what we call non-metastatic breast cancer. So maybe that's a better word to use. So 54-year-old lady presents without any significant medical history, and there's no family history either, and there are no known genetic mutations, which obviously was tested later. This was her initial mammogram, which obviously shows a lesion, a very obvious circle there. And this was on ultrasound, where if you notice on the right side, there actually is a axillary lymph node, which is quite large and inflammatory with loss of hilum. This was an MRI diagnosis. And this is the characteristic. Can I start with you, Dr. Harit? What would you typically want to know more or do in this patient like this? Okay, okay. Bhuvan, PET CT, something else?
I'm okay with the PET scan also.
Huh?
I'm okay with the PET scan also.
No, you're okay with the PET scan? And I think most of us would end up doing a PET scan.
So patient is also happier. Patient is also happier with PET scans.
So we all, I think, become happy, and I think it's a matter of a good discussion whether we should or we shouldn't. But it's a lesser of the evil of discussions that we have. So we've done a PET scan, and this patient basically didn't have anything else. And now the question is, there is no distant mesh. This is clinically a T2, clinically a CN1, but this is a big lymph node. Do remember that. And the patient wants breast conservation. Piyush, can I start with you? At what stage in breast cancer patient do you approach? Because we don't end up seeing the patients together. So how do you approach this? The patient does come first to you. Dr. Mehdi made a very good comment earlier in the day that it depends on who the patient sees first. But really, I think that era is changing. So what stage do you pick up the breast cancer patient and say, you know what, I really must have you seen by the surgeon first? Or do you start the chemotherapy?
No, so as has been discussed previously, that multidisciplinary way is the way to go for every patient, irrespective of.
So I agree. I think we're going to discuss this patient at TMB in the group. I'm fine. But I'm saying seeing the surgeon, even if you were going to take it to the tumor board, but seeing the surgeon, would you see the surgeon always? Would you say only if the patient is going to be operated, or are you going to say that because I'm going to start you in chemo, but do see the surgeon? I think that's what I'm really.
No, always. Because it's going to be a part of the treatment trajectory at some point of time, or earlier or later. It's always that.
Okay.
So I think patient has got a lot of anxiety. What type of surgery will be done later? And since we know that surgery is the main thing when we are talking about a local CA-breast, so the surgeon should be there in the loop to start with. Because if some clipping has to be done and some planning has to be done, ultimately if that comes out from the surgeon's mouth, then it makes much more sense and confidence in the patient. So I think when we are dealing with a local disease, surgeon should come first, and then accordingly we have to tell the patient what type of surgery, what type of clipping, what are the outcomes, and all the cost issues also to be discussed, how much stay and everything. So when patient comes first, it's better that patient has clarity and all these things are discussed.
Yeah, very good point.
I think I agree with what Pankaj said. So we do the same way.
And I think I'll add to that yesterday we were in a palliative care group discussion. Dr. Harit was also there. And one point which came again and again was, are we hearing the patients enough? Actually, rather than are we saying enough? And when you do hear the patient, you realize that there are more questions than what you're going to try and tell them. saying something. You want to say something?
No, I'm just discussing the same thing. Even this practice has from the surgeon's perspective also. Like now they have started even referring patients of 1.5 centimeter tumor, which they know there will be no chemotherapy. Still, they send the patient so that patient has a second independent opinion, and patient has that confidence. Patient should go for surgery because patient will be having second, third opinion. He'll be confused. So he should be on. We all should be on same page when we discuss any case.
Like there was a point where we together we were wondering about we should post. We were discuss with the patients together, and these are exactly the situation where that would help. Can I ask you again and then back to Ruben, which are the indications for full mastectomy in a HER2 positive group, or are that definition now gone? It's somebody who
I would say it's almost gone in terms of primary size, but if you have multicentric disease, if you have only two foci, still today there is a consideration regarding conservation. But in some subset of patients, still mastectomy is the
so the node and the skin involvement.
two different things. Node has no play on conservation versus mastectomy. Skin involvement, as I was mentioning, that T3 has no play on conservation. T3 responding very well, you can easily offer conservation. Inflammatory breast cancer, a big no to conservation. However, T4B is an area where gradually we are increasingly doing more and more conservation. But yes, that is a slow take up there. I also want to make one point, Nitesh, that whenever regarding the T status, when you were talking about the medical of just seeing the patient first and everything. So the clinical findings and the T status is something which is today I depend more on ultrasound reporting of the T status than on clinical findings, because you tend to overall underestimate. So that is one area which is gradually picking up.
I often get confused when there's a video, see the node say video, I don't know if skin is infiltrated or not, and then comes in a PET which shows there's a sliver of PET activity. What do you think we should do with that? Because I mean, is this the case for PCS and there's a good response? And with these drugs, we see a phenomenal response. You know, we see the whole tumor disappearing. So you will certainly see the skin normalizing. And are we doing an age-appropriate surgery but not offering environmental approach?
So eventually, PDO, so what we do generally is, if there is a PDO, obviously the BCS is not ruled out. Obviously, the response takes a lot. And I think the biggest problem, as Dr. Said also mentioned, I think it's the multifocality of the tumor. Rather, we had a case today only, in which there was a large lump, but then when it starts to melt away, it kind of leaves 2-3 foci, and then you do not know whether they were 1 or they were 2-3 to begin with. So I think that's the bigger
But
problem.
Dr. I'm asking more about that sliver of PET activity. Because that makes me nervous sometimes that we are missing out.
So, yeah, I get it.
Biopsy.
Yeah. So frankly, T4B is QD orange. Okay, and that also not just about the tumor. If just about the tumor small area, then it is a case where you can safely do conservation. So it is a larger area. What we are seeing on MRIs and on PET CTs is over imaging. Imaging has gone too intense actually. So that should not direct you to. That is why it is said that all MRIs and all these are directed towards more and more mastectomies, because they instill that fear in the surgeon's mind in relation to a lot of these smaller foci. So that should not direct.
I think that's exactly what I was trying to say, that we shouldn't overcall a breast conservation surgery just because of. Can I have my slides on the screen, please? Because I think it can start making sense. So coming back, how often do you use clipping in your practice? What are the challenges of clipping? How does it impact breast conservation patient? And really, what is the definition of an inoperable conservation? So if you could just give me 2 minutes on that, difficulties in clipping and who is never going to be inoperable other than me.
So all patients today will be clipped. There was a time, maybe 5 years back, when we were clipping only after talking to the patient, whether you want conservation or mastectomy. Only those who said conservation will say go for clipping. Today we say all, because the surprise is that most of these patients, they come back, they want to have conservation, and then you are in a soup that you have not planned it properly. And now I have a patient just 3 weeks back who we had conservation after NSCT 20 years back. Okay, at that time there were no clips available, so we used to tattoo the breast. So that mark is still there, and for several, almost a decade, I was practicing tattooing and all that. Today it's all gone. That mark, when I see, I say it's not today's practice. So to answer one question, which patients to clip, every patient will be clipped. That is number one. You had one more question. Two
So I
parts.
said which patient you would not go for breast conservation other than T4.
Today, all patients will be considered for
So
conservation.
I'm going to give you a difficult one. Here's a patient for you who has got advanced disease.
Who has got?
disease and can't afford anthracycline, can't take anthracycline because of let's say allergic reaction or some level of cardiac toxicity. Would you consider this patient for neoadjuvant surgery or neoadjuvant therapy, or would you go with this patient for surgery first? N1 large T, MRM acceptable, N1 large disease, MRM acceptable, breast conservation not needed. Patient had some cardiac, let's say EF is 45% borderline. Would you consider this patient for surgery first?
No, still, I mean, the EF you quoted, we can still go ahead with a neoadjuvant strategy. Of course, the lower you go with the EF, of course, that becomes a bit dicey, because there, of course, we see that because above 40% with a very close monitoring, we have gone ahead with delivering HER2/neu blockade. So yes, trastuzumab can be given over there.
The question is not can we. I think the question is should we. That somebody who is
We should, because of
operable, one node, and I'll just come to how many nodes you have to consider. But one node, would you consider would we have the same parameter, or would you change practice because the EF is like? I think
you operate. I'll just give a trusty question. If you operate this patient and this turned out to be node positive, what do you do next?
Dr. Pankaj?
What do you do next?
I think he's made a point that anyway you have to give systemic therapy. So, but then when you know that you cannot give.
It's not the same though. It's not the same. Adjuvant and neoadjuvant is not the same.
The outcome can be changed. If a patient you give,
Dealing with a complication before you've operated on the patient becomes more difficult in more than one way, including the psychological aspect.
I think if you know that you are not going to achieve PCR because you will not be giving an adequate neoadjuvant therapy, and you are having hiccups whether the patient will continue trastuzumab beyond 2 cycles, some cardiac dysfunction and legal issues also. I think it's worthwhile in that particular patients. You may frankly go for surgery and then go for systemic therapy.
Look, I just escalated surgery again.
Yeah, that's what I was saying. That. So I think that's a valid point. That whenever in such kind of a situation that you may not be able to give your chemo, better to go for surgery.
But rather, we have been doing that. Eventually, if the patient is unfit to receive, and we're not able to achieve a PCR, we might as well operate and then do it.
I think we can't say we can't, but it just becomes very confusing because we are become used to a certain standard practice, and that's because we're seeing phenomenal responses with combination, and then comes across the patient and you don't know which one to challenge first.
And just to add another thing, that who are the patients will not offer BCS. If the patient is not let's say affording coming from a distant place, and if the lesion is say 3 centimeter, where I know if MRM is done, patient will not need radiation. So in those particular patients, because so many patients are not that affording, so in those particular patients, we tell them if you go ahead with MRM, you will not need radiation. So that's another thing to be added.
Right.
just a modification, Dr. Nitesh, I think in this situation, sometimes if it is decided that yes, we'd like to take an neoadjuvant, modifying a TCHP to NAP paclitaxel carboplatin and subcutaneous, let's go.
I'm going to challenge a little bit there in a minute once we come to that, because we're going to talk about anthracyclines and taxanes and everything. But so you hold your mic. I'm coming to that in a second.
Okay.
So in this patient, the question was what to do. We started, and obviously these are the things we've already discussed, so I won't delve too much into this. And which treatment. So now this is the question, and I'm going to paint these situations. Patient can't afford, and patient has that ejection fraction of 45. What are you going to take your risk with your HER2 for a year or with your anthracycline? So keeping that in mind, what therapy would you choose? So I'm first saying this patient is absolutely fine. Cost is not a concern. I think we are going to use TCHP. So let's close that chapter. I'm not even asking you that. I'm saying now let's think of a clinical situation where first patient cost is a concern. Say T2N1 cost is a concern. And then maybe Pankaj can take the cost is not a concern, heart is a concern.
If cost is a concern, I would take.
Your cost is a concern.
So the cost is a concern, then I think TCH is what we do. So TCH and then followed by maintenance.
TCH? Not AC and NT.
Anthracycline, the ACTH, I think we know that TCH in HER2 positive patients, so TCH has an edge over the ACT. So ACTH, we know that we have a trial of whether the anthracycline versus carbo TCHP. So that's not going to be equivalent.
So we unfortunately don't have Mark on this, but we asked this question to him last time. He said, we give anthracycline to everybody first in Newcastle. Everybody. They don't do TCHP.
So earlier you used to do it in a ERPR positive, HER2 positive setting where we probably used to give maximum benefit. We would not see the much path CR rate. So we used to give benefit of both anthracycline and anti-HER2. So, but we have a data now that getting away with the anthracycline is good enough that if they're equivalent.
Pankaj, I'm tempted to ask you cost question again. Actually. Then I'll ask that question to Piyush and Bhuvan. If cost is a concern, everything else is fine.
With the ejection fraction of 45%.
No, ejection fraction is fine for now. So
for me, whether cost is constrained or not, I'll be sticking to TCH. Okay. I'll not be offering per data to this patient.
Okay. Piyush, now heart is a problem, cost is not a problem.
No, anthracycline is a big no. If heart is a concern, yes, as I said, that we are giving with a close monitoring with the ejection fraction beyond 40%. We have been following that. So, yes.
You've done weekly as well, the 52-week scheduling and all of that.
With the paclitaxel, yes, not necessarily the docetaxel schedule, yes, but with paclitaxel it goes.
Bhuvan, anthracycline is a big no here, or actually 1 year of
finance is a concern. Then ACTH, if the heart is also a concern, weekly pacli with but adjuvant setting, not in intervention setting. Adjuvant setting, weekly pacli with transfusion.
So if cost is not a concern, heart is a concern, you will not start neoadjuvant, you will go to adjuvant.
If cost is not a concern, but heart is a concern. We already discussed that. Probably depend upon the other factors in the performance status.
So what I'm hearing is that for most of us, heart, even if heart is a slight concern, we are actually accepting Herceptin, pertuzumab, provided you obviously operated on this patient and in the adjuvant setting. So that is nice to use. And other than cost, we would not consider anthracycline at all. And actually, half of us would, 3/4 would not even consider anthracycline if cost is a concern. And if the load goes up, maybe Chandrabhadan, you can take that. If load goes up, N2 and N3.
I think then personally I can consider, but we have a data. That's what I want to say. So we can get away with the anthracycline nowadays. So in that context, I'm good enough to use a TCHP.
Pankaj, how many nodes do you FNAC to know whether this is N1 or N3 in a clinical setting? So we talk about increasing nodes. Sometimes the question of anthracycline comes in for some of us, but we only FNAC one node.
Yeah.
So we don't really know this is N1, N2 or N3 based on PET, and we're already saying that PET is not reliable.
If it is,
Actually, I was going to say that.
Supraclavian involvement, then that's a different thing. But just in axilla, I don't think there's any method to tell that how many number of nodes are there.
Yeah, actually, it's the other way around also, that at times they say that the node is there on PET and MR unless you do an sampling.
You need to have a microscopic vision for that.
Recently, we had quite a few patients where the FNAC was negative, imaging was suggesting disease.
Yeah.
And negative, we did the upfront surgery, sentinel node negative. So don't rely only on the imaging.
Me and you had this discussion, and I think the end result of this was you would prefer Anthra, and I would say that there is no data. And eventually, we both agreed that we will reverse sequence it. We'll do TCHP, and then if the patient doesn't have a response, we might add Anthra in the latter half of the.
I think I'll go to the next point very quickly. This will get very confusing, but yes, I still somehow I'm very.
If someone is not responding to TCHP, I'll review the HER2 positivity. If something is not responding to TCHP, maybe the HER2 positivity is wrong.
But to be fair, there is that group of 10-15%. It's not 100%. There's a group of that 10% don't respond to HER2 positive, and in fact, they're still HER2 positive. You get HER2 fish. In fact, this patient had HER2. I'm just saying that there's no clear answer. I somehow am very anthracycline pro when I can't use pertuzumab, but I would not hold anybody against this. We all know that there was phenomenal response to HNP even over the chemotherapy. And Dr. Harip showed these guidelines where the combination is clearly the better thing to do. the question then becomes is, would you consider Herceptin and pertuzumab? And I think the consensus seems to be maybe a quick word starting from Bhuvan Author. Would you consider residual disease, PDM1, agreed. Not pathological CR, HNP versus H, cost not a concern.
HNP.
HNP.
So, of course, cost not a concern with various guidelines saying HNP is a discussion, but if cost is always a concern, and that's what it is.
Then H
So
fine.
then, if you look at the affinity data, the major delta upshift is actually at N2, what I feel. So if I take from there,
Upfront, we don't know if H2 or
Sorry.
N1.
So you're not taking an FAC, never
But
represent
from the affinity data, I'm saying the
You're
N2.
not doing a,
So
you're not doing.
pathological CR. We don't know whether it was N2 or N1.
So cost is not a constraint, give both.
Okay. Cost is a concern. H.
Only H.
Enough.
H for 6 months or H for
1 year, complete 1 year.
H for 1 year because nobody used anthracycline.
No.
Yeah.
Cost was a concern. We didn't use anthracycline. Now we're using H for a year. Anyway, we'll keep that away for later. Okay, these are the guidelines. We've, I think, all seen that. Now let's talk about Fesco. So that's we have 4 minutes left. Experience, they all experience Fesco now.
Yeah.
You all experience Fesco. What's your take on it? Maybe you can start.
So I think with the patients that I've used, they feel comfortable compared to IV. So I think it's less time consuming compared to IV, and easily taken. So that's what it's too early to say. It's just
It
I
made
just
me get excited.
Absolutely.
I found my patient who actually switched over was so excited that she was going home.
true. But I think yeah.
And I said, but you still have to be observed. She said, that's okay. You can send me coffee, but I'm like, yeah, I'm disconnected.
Agree. Completely agree.
Dr. Patrick,
We have just given it to one patient and I think we are comfortable and happy.
okay, Piyush.
Yeah, I think so. It's a big experience changer. I mean, of course, the patient would feel comfortable about it. And what Dr. Harit sir said, that it is going to change the practice towards probably a daycare, home care, OPD. Don't know.
Yeah.
So both me and my patients are both apprehensive because they come and ask me, किसी और को मिलना शुरू हुआ कि मुझे ही मिल रहा है?
And more consultants apart from medical onc will be using this.
There were 3 patients.
And they're still apprehensive.
No, so
in
I rather
first patient will be apprehensive.
I rather did the first. We do a reassessment at the 3rd cycle. I did a first reassessment at the 3rd cycle and did show a response. So I was like, अच्छा काम कर रहा है.
So then more specialties apart from medical onc will be using it.
So now let me throw 2 questions here. Okay, I don't know if I'm allowed to do this or not, but I'll still do it. So we know the cost is cheaper because the cost of Herceptin is not there. Thank you, Losh, for that. I don't know if I'm flouting any regulations here or not, but cost is cheaper. So there is an advantage, and maybe proven towards Chandraghat at this time. Second, what are the difficulties you're going to face with Fesco? And be very open about it. So what are the advantages considering cost is an advantage? Would you therefore advise to everybody because cost is a slight advantage? It's slightly cheaper if you had to use HMP than use IV formulation. And what are the big roadblocks that you see?
So I think once I develop a confidence in this drug, there is no reason not to advise it.
No roadblocks.
It's a no roadblock. It's eventually there's a huge cost difference. There is almost if you look at the long run HNP, there's almost a 10 lakh rupee difference in the entire thing, which is a
Will
huge.
that roadblock not exist when it goes home?
When it goes, acha. So but then and I don't get offended, but then that's what they're trying to change. They're trying to change the physician's behavior because they want to drive across the point. So
I think I'm just feeling a bit naughty today.
I don't think it will be a roadblock.
So, a good drug overall looks like to be, and only thing is that the data on low BMI, I would want to see that more.
I think it's both the end of spectrums, the low BMI and the overweight.
That we need to see,
That's a very
and skin
Always
reactions,
slightly over treatment on most accounts. So it's
Yeah,
not
so-
under treatment, it's over treatment on most.
and somebody having skin disease patterns or atopy or allergies. So we need to see.
Okay, and I think I'm slightly worried about diabetics also because of intramuscular.
Yeah, I think there's nothing to add. Sir has already limited.
I think no points to add. It's a comfortable.
So Dr. Harit, back to you. I think you were saying this is more about patients and not me time. But that does mean, and I do feel that we do need to re-innovate also in how we practice, because patients are not really trying to cut corners. As long as we can develop a system where we can deliver this at home, and then I think it can be done.
Absolutely. The center of all this exercise is the patient and nothing else. And all of us will grow only as the patient gets served. So I think all these roadblocks will not be there. Even if it moves to the home, something else will happen.
So I think this was essentially
So just to ask, we are having so much of emphasis on the subcutaneous pertuzumab, all these things. How come this trastuzumab didn't kick up? Subcutaneous trastuzumab.
I mean, the simple answer is Roche was not interested because that time it was still like patent. Now it is not. But the real answer is, if you see both of them, there is an add-on treatment time which is getting longer and longer. I do remember this was not developed for our country. It was developed for a country where chair time is extremely important. You do have to serve the X amount of patients no matter what. And the minute you can't serve because your treatment time is getting longer, you have to make expansions. You have to create chairs. So the chair time is extremely important. And this 1/3 patients, this is going to be all comers in US. So 1/3 patients sitting chair time actually means that most of the units don't have to cause expansion in the unit.
So, but then why not trastuzumab?
Because you're adding 2 drugs. Suddenly your calculation is getting lopsided. That's my take, but so this is
Something
essentially
more to it. We don't know.
we just discussed this. I think my time is over. I will try to end with a quick summary to say it is in the guideline. My initial experience has been exquisitely good. I'm wary of the diabetics, so we are using a little bit more methods to make the area clean, and I think that should be a concern. But there's no real concern in my mind. I do buy the point about the weight. I think overweight and underweight is an area we have to be careful about. So if I really get that 9,500 kilos patient or the 40, I think I'll be a bit wary. I'll still go back to my previous dosage because that's easy to do. Other than that, thank you very much and thank you for the panelists. Thank you.